this is a big thank you to you, Dr. Ritu, off the screen, that we meet people from different countries also, just because of you.
Warm welcome. It's my pleasure.
Okay, thank you. Thanks a lot.
Good evening, delegates.
Across the globe.
Shall we start, ma'am?
Yes, please. Yes, please.
Good evening, delegates and all the participants. Welcome to Mixed Bag webinar. And let me introduce our expert of the webinar, Dr. Rekha Gupta. She has done MBBS and MS. Ma'am is an infertility and IVF specialist and director of Sanjeevani Test Tube Baby Center, Kanpur. Ma'am is currently treasurer of Kanpur OBGYN Society, secretary of IHRF Kanpur Society. And today we are going to discuss two important topics in this webinar. And first topic is taboos to treatment for male infertility by Dr. Ritu Santwani ma'am. And the second topic is LPD by Dr. Kanchan Mala Gupta ma'am. Let me introduce Dr. Ritu Santwani ma'am. Ma'am has done MD, FICOG, FIAOG, AMR COG. Ma'am is an obstetrician and gynecologist IVF specialist, founder and CEO of 360 Degrees Healthcare Studio. Ma'am is consultant at Inamdar Multi-Speciality Hospital, Pune, and Infertility Test Tube Baby Specialist. Ma'am is a part of NUHS Singapore and co-founder of MAAM, board member of SWWC. And our second speaker is Dr. Kanchan Mala Gupta ma'am. Ma'am is an obstetrician and gynecologist, infertility expert, sonologist, laparoscopic and hysteroscopic surgeon. And currently, ma'am is working in Ashirwad Maternity Center, Kanpur. And I would like to hand over the session to Dr. Ritu ma'am.
Yeah, thank you, Sahiti. Sahiti, please check the program is going live or not. I'm getting 2-3 messages.
Okay, ma'am, I'll check.
Yeah. So, warm welcome, dear friends. As all of you know, this weekly series is based on the knowledge sharing, and in this new digital era, knowledge sharing is the key mantra. So I am very lucky, and I can say I am honored to have two of my seniors from my college only. A very, very warm welcome of our chief guest, Rekha Gupta ji. Rekha ma'am, warm welcome, Rekha ji. And other speaker is none other than my dearest Kanchan ji. Kanchan ji, a very, very warm welcome. I am really thankful to both of you that both of you have accepted my invitation for gracing this program. So before we start, Rekha ji, if
my
you want,
pleasure.
Yeah. Rekha ji, you can say a few words.
Yeah,
you're looking very pretty in pink. Huh?
Thank you so much. It's really my proud privilege, because I look up to your program as and outlet for us, people just restricted to Kanpur. So just because it's by God's grace that like I found your friendship, so we have the access to so many people who only we heard the names, and so we can be there with you, and it's my great privilege. And of course, Dr. Ritu, as we all know, the knowledge sharing and the vast knowledge she has in every subject. This is all because of her webinars through these. I think it's 4 years now, no, Dr. Ritu?
Yeah. Yes.
4 years, 5 years, yes.
Yeah.
So, and very different topics, or it's like every Friday, Thursday or Tuesday, whatever day she chooses, we have a very good updation of our knowledge, and it's all for free. no traffic problem, no rushing about here and there, very cool time. So that's all very great about the webinars, and I wish you all the best, Dr. Ritu.
Thank you, Rekha ji. Thank you so much. So friends, now we are going to start with the first topic. I want to invite Kanchan ji. Kanchan ji is my guest today. So instead of me, I wish that Kanchan ji, yes, Kanchan ji, you please first take a... No, you start. See, friends, Kanchan ji is going to discuss today a very, very important topic, the luteal paste effect.
You are more expert.
Today you are expert. I am not the expert. So yes, first you take this for luteal phase defect, and later on I will take that. So friends, as we all know, we all are having the lot of queries and confusions for this luteal phase defect. So let us listen first to Kanchanji, that what she is explaining about that, and later on you can write your queries in the question box, and later on we can discuss all that. So over to you, Kanchanji. Welcome, dear
Yes.
friend Pratima. Pratima has joined. Pratima, welcome. And other
Dr.
friends who
Kanchan is
have
also very,
Are you
very
able to see my
knowledgeable.
slides?
So let's.
yes,
Thank you.
your slides are visible. Yeah, and your voice is also coming clear.
Thanks, Dr. Ritu.
Yes.
And,
Yes,
my
yes, clear.
topic given to me by Dr. Ritu is luteal phase defect. Luteal phase of menstrual cycle begins. I'm not wasting time. I'm starting shortly. The luteal phase of menstrual cycle begins after ovulation and lasts about 14 days and ends just before a menstrual period. Luteal phase events are dependent on follicular recruitment and folliculogenesis. And there is a shift of FSH dominance to LH dominance in luteal phase. And the normal length of luteal phase, usually non-fertile cycle, varies between 14 to 16 days, as already told I am. And after ovulation, luteinization of the granulosa and the theca cells occur. Progesterone
Dr.
is produced.
Kanchan, Dr. Kanchan,
Yeah.
can you put it on full screen, please?
Yeah. Okay.
Screen only, ma'am.
Achha, is it full screen?
Yeah, this is full screen only. No, full
Okay,
screen
thank
only,
you.
Rekha.
Okay, thank you.
No, Kanchanji, go ahead. It's clear, loud and clear. Yeah.
So progesterone is produced which maintains luteal phase. Voice clear, Ari?
हाँ, बिल्कुल clear.
बिल्कुल.
Estrogen priming of the endometrium is mandatory for progesterone to work. And the theca cells derived from luteal cells are responsive to LH and produce progesterone. So corpus luteum is the best luteal phase support. In LPD, luteal phase is not capable of implantation or maintenance of pregnancy. Luteal phase may be shortened in length with relatively normal progesterone levels. There may be a normal length of luteal phase with adequate progesterone production, and there may be inadequate response of endometrium to normal progesterone production. And there is prevalence is variable in the infertile to recurrent pregnancy loss, 3 to 20% infertile, approximately 5 to 60% in RPL patients. About 26.5% of the infertile patients, the underlying condition is LPD, and in 40% of patients suffering from RPL, the underlying cause may be LPD. This is the simple picture that everybody is aware. Once fertilization occurs, the corpus luteum is stimulated by human chorionic SCG and continues producing progesterone. So progesterone is required for several processes in early pregnancy. Preparation of the endometrium for implantation, for secretory changes, decreases contractility of uterine smooth muscles, regulation of cellular immunity, mediates uterine blood flow, uterine endothelial adaptation to pregnancy, increases nitric oxide production. So inadequate functioning of the corpus luteum affects amount of progesterone which is produced and duration of the progesterone secretion. So there is possibility of decrease. There is also the possibility of decreased number of nuclear progesterone receptors in the endometrium, resulting into inadequately prepared endometrium for implantation. So mainly the most important causes are poor follicle production, as already told, poor folliculogenesis, defective or poor quality or malfunctioning corpus luteum, premature failure of corpus luteum, and failure of underlying uterine lining to respond to normal levels of progesterone. See, it is an important definition which was given in 1949 by Georgiana Jones. Corpus luteum defective in progesterone secretion, which in turn is cause of infertility or early spontaneous abortion. Treatment of, there are also luteal phase deficiency in IVF cycles, which you can better tell IVF is associated with luteal phase deficiency. After oocyte aspiration, there are supraphysiological estradiol level caused by ovarian stimulation has a negative feedback on pituitary. There is also, it also promotes premature luteolysis and low serum progesterone levels during the luteal phase. These all impair corpus luteum ability to produce sufficient progesterone. So there is possibility of sporadic abnormalities of luteal function in fertile women. So LPD is clinically relevant only if it is presenting in persistent most of the menstrual cycle. Requirement for 2 consecutive menstrual cycles as currently applied to the diagnosis of LPD is arbitrary. The pathophysiology of luteal phase defect includes a series of reproductive hormonal abnormalities like supraphysiological LH pulse frequency leading to LH surge of decreased magnitude, decreased secretion of progesterone, estradiol, and inhibin. And there is decreased biopotency of LH in the mid to late luteal phase. All these lead to premature luteolysis in subtle reduction in luteal phase duration, and subsequently menstrual cycle is altered. And there are also changes in the endometrium. Alpha beta 3 integrins normally appear in the endometrial glands on cycle days 20 to 24 days during the window of implantation. Supplementation with progesterone restores normal endometrium histologically and normal alpha B beta 3 integrins levels. Limitation of serum progesterone level measurement is not accepted because there are fluctuations of progesterone owing to pulsatile release of LH and lack of correlation of serum progesterone levels and the endometrial histology. So and there is also close relationship between luteal blood flow and luteal function. Luteal blood flow significantly correlates with serum progesterone concentration during the mid-luteal phase, and it is lower in patients with LPD. What are the risk factors which promote for LPD? ART techniques, obesity, polycystic ovary syndromes, thyroid dysfunction, hyperprolactinemia, dopamine sensitivity की वजह से hyperprolactinemia में भी problems हो जाती है जिसकी वजह से pulsatile release of LH नहीं हो पाता है. Ovulation stimulation alone, ovulation induction with or without gonadotropin releasing agonist, endometriosis, aging process, whenever there are eating disorders like anorexia, starvation, excessive stress, exercise, if more than 7 hours per week, excessive stress, inadequately treated 21 hydroxylase deficiency. So what are the consequences? There may be of LPD. There may be unexplained infertility, irregular cycles, premenstrual spotting is there, history of recurrent pregnancy loss, premature ovarian failure, and maybe ectopic pregnancy. So what are there are no definite diagnostic criteria, but diagnostic tests are based on the following physiological observation. Normal luteal phase length varies between 12 to 14 days. And progesterone levels peak in 6 to 8 days after ovulation in the non-pregnant cycles. Progesterone is secreted in pulses, and the endometrial response, which is a reflection of the follicular phase estrogen and the luteal phase estrogen and progesterone, is very important. Once implantation occurs, progesterone secretion by the corpus luteum depends on the rising SCG levels, and failure of SCG levels to increase directly causes corpus luteum failure and a decline in progesterone levels. And there are different methods which help in assisting but not conclusive. These may be basal body temperature, urinary LH surge detection kits are available, serum progesterone levels, and endometrial biopsy. While an interval of 8 or fewer days from the time of an LH surge is consecutive evidence of a short luteal phase. However, short luteal phase may occur in healthy young women. It is endometrial biopsy is also not a valid clinical diagnostic tool. I've already told progesterone secreted in pulses that reflect LH pulse level may fluctuate up to 8 folds within 90 minutes. In the absence of pregnancy, progesterone levels peak 6 to 8 days after ovulation. To determine peak progesterone level, it is necessary to determine the time of ovulation. And the UK MHRA recommends serum progesterone level more than or equal to 14 nanogram per ml in the mid-luteal phase for maintaining pregnancy. What are the strategies? I am not focusing more on treatment part. It will be told by Dr. Ritu, which is expert in LPD treatment. Mainly the strategies include SCG in the luteal phase, progesterone supplementation, and the progesterone plus estrogen. As well as there are two important causes of luteal phase defect: hyperprolactinemia or abnormal thyroid function, and the clomiphene citrate, which is used as first line treatment modality for LPD. Clomiphene is not used as first line treatment modality for LPD, as it can potentially cause LPD itself. However, CC can be used in case of LPD who have short or abnormally long follicular phase, who ovulate at follicle size less than 18 millimeter. So these are the cases of abnormal folliculogenesis. SCG provides indirect form of luteal support by stimulating corpus luteum, increases estrogen and progesterone concentration, thereby rescuing the failing corpus luteum in stimulated IVF cycles. There may be risk of ovarian hyperstimulation syndrome. So approaches to the treatment of LPD. Strategies are progesterone supplementation, progesterone estrogen supplementation, SCG supplementation in the luteal phase, ovulation induction by CC or gonadotropins. What are the advantages? Promote endometrial maturation, enhances endometrial receptivity, support implantation and development of early pregnancy. So characteristic of an ideal drug. So what are the characteristics of an ideal drug for treatment of LPD? It must restore the normal secretory endometrium. It must increase the number of nuclear progesterone receptors in the endometrium. It must be non-luteolytic. Patient, if desires, should become pregnant during or after treatment. Should neither cause any fetal abnormality nor cause any undesirable effect on the mother. So rationale for luteal phase support in pregnancy. Progesterone secretion by the corpus luteum is required absolutely for the success of early human pregnancy. So progesterone supports endometrial growth, improves blood flow and oxygen supply by increasing nitric oxide production, keeps myometrium quiescent by uterorelaxing effect, and sustains survival of embryo by shifting immune system towards production of T helper response. So why progesterone for LPS? There is upregulation of progesterone receptor on activated lymphocyte among placentas and deciduous CD56 plus 56 plus cells. So in the presence of sufficient progesterone, these cells synthesize a 34 kDa protein named PIBF. Everybody knows about PIBF, which is a mediator that exerts substantial anti-abortive activities. So all of you know very well the effects of progesterone on the endometrium, secretory transformation of the endometrium, implantation in the early pregnancy, tortuous and the secretory gland changes, and increase in the stromal vascularity. These all changes prepare the endometrium, make it morphologically, biologically, and functionally for implantation. Rationale for luteal phase support in ART techniques. Dr. Ritu and Dr. Rekha, you are better. Both of you are better assessment. You both have. In ART, low progesterone environment is created iatrogenically due to interventions. There are uses of GnRH analogs, both agonist and antagonist, which suppress gonadotropin secretion. Once down-regulated pituitary function does not resume until 2-3 weeks after the end of GnRH therapy. As corpus luteum function is dependent on pituitary LH stimulation, the luteal phase support is considered prudent to prevent any progesterone deficiency that might jeopardize the success of implantation or failure of pregnancy. SCG administration for final oocyte administration suppress the LH production via a short loop feedback mechanism. Supraphysiological levels of steroids secreted by higher number of corpus luteum during early luteal phase directly inhibit LH release via the negative feedback mechanism. Luteal phase LH levels found to be reduced in HMG only cycles also, which indicates defective LH secretion might induce a luteal phase defect in stimulated cycles. There is role of progesterone supplementation like natural micronized progesterone, dydrogesterone in various formulation, oral, vaginal, intramuscular, subcutaneous routes. So choosing the right progestogen, what does the evidence say? So criteria for doctors, what are the criteria? How can you choose? It must be evidence-based, efficacy of the drug, safety and side effect, and what are the results? Criteria for the patients. It must be convenient for the patient, palatability, tolerability, ease, results, availability, as well as cost. So important points for LPD are, LPD is relevant if present in most of the menstrual cycles. LPD can only be diagnosed after repeated testings. Requirement for 2 consecutive menstrual cycles is also arbitrary. LPD has multifactorial causes. Still, medical literature has failed to confirm its true existence. 3-pooled luteal progesterone levels seems to be the best way to diagnose LPD, but not confirmed. Detecting and correcting defective follicular phase defects can correct luteal phase defects because it is mainly the ovulatory dysfunction. Thank you.
Thank you, Kanchanji. Thank you. Thank you so much. Especially the slide which is showing all the indications and in which conditions the LPD is very common is very, very useful. And thank you for such a nice presentation.
We focus mainly on pathophysiology part.
But you covered very nicely. All the points are covered. Yeah.
The pathophysiology was wonderful. Like I was just, there was some disturbance in the laptop, and I was, because previously I was saying about the screen, so it was actually, I told Dr. Ritu about my laptop. So, so many points were very, like remembering our MBBS days, everything was taken care of right from the receptors. Like very good,
very nice.
Points. It was very elaborately given, and I would just like to add simple.
Rekha ji, your camera is off. Rekha ji, we are not able to see you.
Acha. So yeah, that actually it is not my laptop, and then it becomes like, if you have someone else's.
Acha, okay, no problem. Carry on. I thought you are not aware.
There is some problem. So like for LPD, in recurrent implantation failure, like though it's pertaining more to RIF, but still patients of RIF should also be investigated for LPD, recurrent implantation failure, by IVF specialists. And also when we see infertility, and there's so many things, but as Dr. Kanchan has really brought out well, that it is a major cause of for infertility as well as recurrent implantation failures. So yes, that point I just wanted to, that we should keep in mind. Well, like it is like keep thyroid in your mind, then keep LPD in your mind for any of the cascade of infertility, RPL, RIF, habitual abortions, all that. So thank you so much. And Dr. Kanchan, it was an excellent talk. Very nice.
Yes, very nice presentation. नहीं नहीं वो तो बहुत कंचन जी, because you have because LPD is such a vast topic, so covering in few slides and covering all the salient points, which are the main points what you have covered, is very nice, very nice. Now Rekha ji, we can see you.
Yes, thank you.
So
Thank you
friends,
so
if any questions related to LPD, please do write in the chat box. Kanchan ji, you are with us or leaving?
I'm with you.
Achha, okay. So now, without wasting time, I am starting the sharing of my screen. So I am going to speak on the male and infertility from taboo to treatment. My slides are basically of the awareness PPT. So this is the awareness PPT that we are getting so many of patients of this male infertility also, and lot of taboo is related to that. So making it full screen.
both are very well chosen topics. Very well chosen.
Thank you, Rekha ji. I think my slides are full screen now.
Yeah.
Yes.
Very nicely. You can see.
Yeah. So friends, yesterday only we have celebrated Ram Navami. So my all presentations will start with Mata Durga Stuti. Ya Devi Sarva Bhuteshu Chikitsa Rupen Sansita Namastasyai Namo Namah. So friends, we all are aware regarding this male infertility. A lot of queries everyone is having these days. We are getting a lot of patients in our OPD. Earlier it was happened ki only the female infertility, but now the male infertility is also on high. So this slide is basically kind of awareness PPT. So I will take only the salient features, not all things. So as we all know that we can go for the last line, that about 1/3 of the infertility can be attributed to male alone factors, and about 1/3 of the female alone factors. We all know about the primary and secondary infertilities. I'm not going to take that. So male infertility refers to a male's inability to cause the pregnancy in a fertile female. So WHO has changed the definition also. Earlier it was that only the male infertility refers to a male's inability to cause pregnancy. Now the recent guidelines have added this word to cause a pregnancy in a fertile female. So friends, as we all know, regarding this, I am taking these points because this show has been watched by from the beginners to the seniors. So aspermia means failure of emission of semen, no semen. Oligospermia or oligozoospermia, in which the sperm count is less than 15 million per ml. Azoospermia, no spermatozoa in the semen. While asthenozoospermia, in which reduces sperm motility. Necrozoospermia, in which the spermatozoa are dead or motionless. Teratozoospermia, more than 70% of spermatozoa with abnormal morphology. Oligoasthenozoospermia, disturbance in oligoasthenoteratozoospermia, in which the disturbance in all three variables. Yesterday only I got one patient. The patient told me, ma'am, I approached to a doctor whom I consulting. My report was showing the oligoasthenozoospermia, but the doctor is not able to clarify me whether it is the Tirato or whether it is only astheno. So these days by Google, patients are coming and reading so much. So we have to update our knowledge very much. So according to this epidemiology, about 15% of the couples do not achieve pregnancy within 1 year and seek the medical treatment for infertility. Approximately 50% of the involuntarily childless couples, a main infertility associated factor is found, usually together with abnormal semen parameters. Male infertility accounts for 40 to 50% of the infertility and affects around 7% of all men. So normozoospermia was observed in 35.80, oligozoospermia 34.14, asthenoteratozoospermia 19.35, azoospermia in 10.70% has been reported. So friends, Here is the slide which is showing which are the problems which are causing the male factor infertility. We can see the environmental toxins, exposure to radiation, exposure to some drugs, smoking, yes, plays a very important role, hyperthermia, psychological stress, varicocele, mitochondrial abnormalities, lifestyle factors, genetic factors, and the infections. So the different problems which has been reported are structural abnormalities, sperm production disorders, ejaculatory disturbance, and immunologic disorders. So causes of male infertility. Yeah. In this, we can see either the hypothalamic hypophasia, in which the pituitary insufficiency, hyperprolactinemia, Kallmann syndrome, hemochromatosis, pituitary tumors, and chronic illness has been reported. Among these testicular disorders, infection, Klinefelter syndrome, testicular atrophy, Y chromosome deletion, and systemic disorders has been reported. Sorry for the spelling mistake for Klinefelter. Seminal tract disorders, retrograde ejaculation, obstructive zoospermia, while in immunological disorders, autoimmunity to sperm and psychosomatic disorders has been reported. So friends, here we can see, so these are the risk factors. So we can see smoking, alcohol. So for male, risk factors for this has been reported a precocious puberty occurring at a young age, delayed puberty occurring in the older age, exposure to toxic substances like lead, cadmium, mercury, radioactivity, and X-ray, smoking, cigarette and tobacco, and heavy alcohol consumption. So these are the two recent guidelines I published, that precocious puberty occurring at a young age also causes the male infertility, and delayed puberty occurring at an older age. So obesity, we all know, is also a cause of the male infertility. So we can see how it is prevalent in different countries and how it is affecting. In India at present, for this is being overweight is around 13% has been reported. So what are the other factors? Other factors, as we all know, exposure of the genitals to a higher temperature, surgical injury to the vas, especially after the inguinal hernia repair on both sides, having prior vasectomy or major abdominal or pelvic surgery, history of undescended testicles, having experienced trauma to the testicles, being born with a fertility disorder, medical conditions like diabetes, sickle cell disease, or undergoing some surgical treatment or radiation used for treating cancer. So now what are the complications associated with this? As we all know, social and emotional stress, relationship difficulties, expensive and involved reproductive technique, increased risk of testicular cancer, melanoma, colon cancer, and prostate cancer has been reported. Now, while the clinical evaluation with the history, we are going to ask illness or injury affecting the testes, pubertal development, sexual performance, fertility exposure, occupation and habits. While on the examination, the general examination, virilization, gynecomastia, body proportions and BMI, scrotal examinations, testicular size, epididymis, vasa, and varicocele we have to see. While with the investigations, we all know the semen analysis, in this the concentration, motility, morphology, and sperm antibodies. While among the hormone, the LH, FSH, prolactin, testosterone, and sex hormone binding globulin has been reported. But we all know basically the first only the two tests we are doing, the analysis and the culture. And then the scrotal ultrasound, transrectal ultrasound of prostate and seminal vesicle, MRI of pituitary, testicular biopsy, needle aspiration, or the true cut biopsy has been reported. We all are aware by this recent now the WHO 2010 guidelines. So we can see the volume, as we all know, 1.5 ml, concentration 15, sperm count 39, progressive motility 40, and the morphology 4% has been reported. This is just a revision kind of slides. So again, from the Andrology journal, it has been reported the using microRNA as a molecular biomarkers for the evaluation of the male infertility. This has been published very recently in 2021 November. They have shown that semen analysis has been considered as a critical assessment to diagnose the infertile men. Then the studies have shown that these weakness of the semen assessment indicate a global need for the novel and better diagnostic tools and biomarkers. MicroRNAs are short, about 18 to 22 nucleotide length, non-coding RNAs that control most of our protein coding genes post-transcriptionally. These molecules are aberrant in the body fluids, and abnormal alterations in their expression levels can signify a specific disease such as infertility. So studies have shown that this microRNA can be a novel candidate biomarkers which can diagnose different type of male infertility, including azoospermia, oligozoospermia, actinozoospermia, and teratozoospermia. Again, the studies has been published. These studies are all published only in 23rd February 2022 only. We can see in IGR journal. The studies have shown the clinical utility of serum 17-hydroxyprogesterone as a marker for the medical therapy for male infertility recommendations based on the clinical scenarios. So the studies have shown that 17-hydroxyprogesterone has not been widely adopted as a clinical tool in the evaluation of the male infertility, which likely stems in part from the lack of concrete indications for its use. So now a lot of studies are coming in the favor of that this 17-hydroxyprogesterone is promising as an acute serum biomarker for intratesticular testosterone. Earlier, we are doing only the serum testosterone. Now, a lot of studies are coming in the favor of doing the 17-hydroxyprogesterone. Still, a lot of research has awaited, because after this, I have searched so many articles yesterday for this, the recent updates in the 2023, but all are saying that a lot of studies are still going on. So, this what I found in the literature, that's why I posted the slide. So friends, here we can say the male infertility is an underdiagnosed health problem. It should be studied in a comprehensive manner. Hormonal evaluation of male infertility should include the determination of testosterone gonadotropin hormone levels. The spermatogram is the cornerstone in the male infertility evaluation. Sorry. So it is a laboratory test, as we all know. So here we can see this study has shown this study has been presented in the Elsevier journal, which is a very reputed journal for the male infertility. This study also has been presented in 2022. I have put this link. Anyone can go through the Google and read this. The cornerstone of the evaluation of the hormonal status is the semen analysis. Clinicians must include the hypogonadism in those patients who present with oligospermia and azoospermia by determining the levels of testosterone and gonadotropins, which provide the functionality of the status of the hypothalamic pituitary testicular axis, and evaluation of adrenal, thyroid, and lectrotroph axis are indicated in those patients with central hypogonadism. So now the treatment for this male infertility, depending on the indication, the extreme oligospermia, azoospermia, low volume ejaculate, or impotency. So we all know the reduction of the weight in the obese, avoidance of alcohol and smoking. In hypogonadotropic hypogonadism, HCG injection 5,000 international units intramuscularly once or twice a week. HMG or pure FSH. Along with that, dopamine agonist cabergoline is given in hyperprolactinemia, pulsatile GnRH therapy in the case of the Kallmann syndrome. While in hypergonadotropic hypogonadism, insemination with donor sperm or adoption, IVF and ICSI. We all know the use of the CC 25 mg orally for 3 months increases the level of the FSH, LH, and testosterone. Presence of anti-sperm antibodies, IUI, can be done, or the leukocytospermia. If anti-sperm antibodies, then of course the IUI. If leukocytospermia, the prolonged course of the antibiotics, usually the doxycycline or erythromycin, has been recommended for 4 to 6 weeks. Retrograde ejaculation, the phenylephrine, use of the phenylephrine, a lot of studies has been done. In the genetic abnormality, yes, of course, we know with the donor's semen. And the surgically, if the vas obstruction is there, to correcting by doing the vasoperiodostomy or vasovasostomy, or the hydrocele if there, then hydrocele surgery, orchidopexy in the cases of the undescended testes. If the impotency, the psychosexual treatment is helpful, and for the erectile dysfunction, the sildenafil or tadalafil 25 to 100 mg single dose given orally 1 hour before the sexual activity. Then we all know the different ART techniques, IUI, TESA, PESA, MESA, and ICSI. All has been reported, because this is a very vast topic. I am touching only in the nutshell. So there are a lot of studies have come regarding the use of the antioxidants, the role of oxidative stress in the male infertility, and updated review. The studies have shown the current evidence links oxidative stress to male infertility, reduced sperm motility, sperm DNA damage, and increased risk of recurrent abortions and genetic diseases. We all know regarding this. So a lot of studies have come that oxidative stress affects negatively the testicular microenvironment and ends up by causing a deficient spermatogenesis, damages to sperm DNA, as well as reduced motility and altered morphology of spermatozoa. Then antioxidants used in infertility treatment in males, the vitamin, we all know the different drugs. The vitamin E has been reported, and vitamin C, the doses up to the has been reported up to the 1000 mg. Vitamin B12 in asthenospermia and oligospermia, it has been reported 1000 to 1500 microgram per day for 6 months. Folic acid also, and the pentoxifylline. A lot of studies have come now, the use of the pentoxifylline in the male infertility, that it improves the microcirculation, improves count and motility, 1.2 mg per day for 3 to 6 months. Friends, daily in our OPD, different company representatives are meeting us with a different formulation, astaxanthin, lycopene, coenzyme Q10. So now what's the role of the each ingredient? Yes, there is no harm in giving this nutraceuticals, but of course, they must be containing this vitamin B12, vitamin C, vitamin E. So we will get the faster good results. Similarly, we know the arginine improves the motility. Selenium is a good antioxidant for the male infertility. Glutathione, L-carnitine, and L-acetyl carnitine also has a role in the sperm cell metabolism, highest concentration in the epididymal fluid. Useful in oligoasthenoteratospermia. Coenzyme Q10, we all know. Lycopene also, and carotenoid antioxidants. They all protect the sperm damage from the reactive oxygen species. Similarly, with this L-arginine, L-carnitine, vitamin C, E, lycopene, and folic acid, and all these, and with the zinc and selenium. A lot of studies have come, their beneficial role in sperm motility and morphology. In the advanced cases, we are doing these two tests, the DNA fragmentation and by chromosome microdeletion. So friends, the importance of treating this sperm DNA fragmentation has been reported to be higher in the subfertile men with abnormal sperm parameters. Higher sperm DNA fragmentation affects the blastocyst development and increases the chances of the failed ART and increases the chances of the abnormal sperm parameters, and miscarriages chances are also increases. So for this DNA fragmentation, also if the patient's DNA fragmentation, sperm DNA fragmentation is coming high, yes, we are telling them for the lifestyle modification, cessation of smoking and alcohol intake, weight reduction, antioxidants, vitamin C, E, folic acid, zinc, selenium, and underlying pathological conditions, varicocele, genitourinary infections, all they have to treat. Then if any environmental toxins exposure, that has to be avoided. Then different other studies have come for the treatment for this is vitamin D3, glutathione peroxidase, superoxide dismutase, astaxanthin, and coenzyme Q10. All are acting on the different, but overall we have to get the good sperm quality, quantity, and morphology. So there are a lot of studies in the favor of this has been presented. Similarly, some studies have come regarding the use of this Tripolus terrestris. The studies have shown that this drug has also giving a good results in the cases of the male infertility. So it has shown in the cases of the oligoasthenoteratozoospermia, protodiosine increases the level of the spermatogenesis by stimulating the Sertoli and Leydig cells, resulting in the increased production of the sperms. So it significantly improves the acrosomal activity, helps the sperm penetration to the xena pellucida and fuse with the oocyte membrane. Similarly, a lot of studies have come regarding the use of this myoinositol for the male infertility. So studies have shown that it is strongly concentrated in the seminiferous tubules, and it plays a very important role in the regulation of the calcium level. Studies have shown that higher calcium levels stimulate the oxidative metabolism, inducing the production of the ATP, and overall the good results with activating this mitochondrial membrane potential. So a lot of studies in the favor of this. It acts as here we can go through the last line. Myoinositol acts as a second messenger, regulates the activities of FSH, thus may result useful to counteract the alterations of the hormone levels. So besides that, a lot of studies have come regarding the role of the vitamin D in both male and female infertility. Studies have shown that DNA damage observed could explain in low fertility potential in the obese and vitamin D deficient males. So addition of vitamin D is also helpful on the different parameters. Lot of studies in the favor of that. So the take-home messages with this, the male infertility is an important health issue. It is modulated by the external factors. Obesity is one common risk factor. Lifestyle modification with diet management and exercise should be considered the first step in the male seeking for the fatherhood. Routine semen analysis might give the idea of the physical parameters of a sperm. Sperm DNA fragmentation test may provide more clear picture. Antioxidants are helpful in decreasing the oxidative stress and DNA damage of the sperm. So there are different role of the interventions to restore the male fertility is much needed, and so consulting physician is very, very important. So with this, I will wind up. This PPT is mostly the awareness PPT from taboo to treatment. As we all know, in the male infertility, there are a lot of advancement these days. So I tried to cover only some nutshell points, because if I want to take a very, very big lecture, can be taken on the different issues. So thank you, dear friends, for your time and attention. Good to see you here, Yajni ma'am. Good to see you here. If any questions, we are happy to answer your questions. I'm not able to find any questions. Rekha ji and Kanchan ji, your comments, please.
Excellent presentation by Dr. Ritu. And there are always multiple confusions regarding treatment for male infertility. Often we are confused oligospermia, oligospermia, and the patient, even mainly the husband, always denies, no, I am totally fit. I am. So sometimes it is very difficult to decide what to answer and how to approach for the treatment. And this is very excellent presentation.
Thank you. Thank you. Thank you. Sahiti, can you please unmute Yajini madam?
Yes, ma'am.
Yeah. Yajini madam, good evening. Madam, can you hear us?
Madam?
Thank you, Kanchanji. Thank you, Kanchanji.
Okay,
Yeah, Rekha ji.
am I audible?
Yes, you are audible.
Today I had a tough time with this, the
Okay.
laptop. So I was enjoying the academic treat, and like it was a, excellent brush up of the whole male infertility, and you brought out some very new points about myo and stall also, and the whole thing was revised. Like the slides were also so, lucid, and बहुत दिन से मेल इनफर्टिलिटी का पूरा ब्रश अप नहीं हुआ था, so that is a lot of good take homes also we got. And
Dr. Ritu, please also tell the dose of letrozole in male infertility.
Yes.
In the cases of oligospermia.
I will tell. Let us first listen. Rekha ji and Yajini madam want to say something. Yes, Yajini ma'am. Unmute yourself. Ma'am, unmute yourself. Yajini ma'am, unmute yourself. No. Madam is... No. We are not able to hear.
In the meantime, Dr. Ritu, just off the main treatment, I just got 2 points from your talk and some other webinars also, that even in azoospermia, in obstructive azoospermia and in like obstructive azoospermia, when the surgeons want to do the operations of, supposing it is a absence of vas deferens. So what they say is then too, even if the patient is going for the operations, you can give a try of HMG for 3 months. So what that will do, because of the obstruction, when there is CVAD, or if there is agenesis of the epididymis, the backlogging has caused the spermatogenesis to be reduced. So once usually the obstructive azoospermia, we think that there is no need of medical treatment, but in that I think the andrologist was telling us that give a course of HMG bi-weekly, or you can also add HCG, and it will give better results even for obstructive azoospermia. So that was a new point I got. And also when they say it is hypogonadotrophic hypogonadism, then of course you will give HMG, as you told in your talk. But in hypergonadotrophic hypogonadism also, they said that the FSH and LH is high. But once you go for PISA, TISA, all this, you can add HMG and HCG to give a better result of the first. The andrologist was saying, I first give a course of HMG and HCG for 3 months, and then I do the TESI or TISA. So very different things. So I thought I just bring it out for general.
That's good. You have shared. See, according to the situation and everything, we have to modify also. Sometimes the patients are not ready. Sometimes they are not ready they are not having the finances. We say about the ICSI or TESA or BESA. So sometimes we have to go for the medical treatment also. Yes,
injections do work. I've seen that if you give injectable, even if we are not going very intrinsically to the whole problem, you give the injections, the patient does bring out a better report. This I've seen for myself.
That's correct. Thank you.
Nice presentation, Ritu. Nice presentation, Ritu.
Thank you, Yajini ma'am. How are you? Yajini ma'am?
Yeah, better. I had a fracture in my ankle, left ankle.
When?
2 months ago. That's on February 2nd. was leaving to airport
Oh.
for Izar.
Okay.
So that's why I couldn't come to Izar.
I thought you are not in India. That's why you are not attending. You are,
Because of this fracture, only now only I have started using stick and walking a bit.
Okay. Please take care, ma'am. Please take care.
But it was very nice,
Get
very
well
nice,
soon,
very
ma'am.
informative.
Thank you.
Okay.
Friends, Yajini madam is a very famous, very famous, having a owner of the Pony Test Tube Baby Center from the Madurai. Madam, it's my pleasure that you have joined the webinar. Thank you. And me and Yajini madam are connected from so many years. Here I will share now. Me and madam met in one conference in the Goa. So only a minute, madam was clicking some photo and I was clicking also the photo of the one slide. After that, we have changed our views. So from till that time, I am connected with the madam, and madam is a very knowledgeable. Madam has presented lot of cases for the endometrioma. So madam, we will do once again your program with you. I will approach you. Yeah.
Okay, Ritu, bye.
Bye, ma'am. Thank you.
Very nice. Okay.
Thank
Good
you,
night.
madam. Thank you, ma'am. Good night.
And get well soon,
Good
ma'am.
night.
Get well soon.
Yeah.
And Dr. Ritu, because of the laptop, one more point in Dr. Kanchan's talk. I just wanted to share my view that when we see when we do our ovulation study, and we just put off the study after the ovulation, but we should call the patient 1 week after the ovulation and see for the corpus luteum color Doppler blood flow. So just put the PRF at very low, around I think it is 25, and then when you see the RI of the vessels, so if it is less than 0.5, then it is good. The resistive index is should be low for the vessels. So that gives a very good indication if you are doing the we are usually doing our TVS, So when you see the vessels are giving a RI of less than 0.5, then this shows that she does not have LPD. And if the RI is less, then she surely has.
Uterine blood flow.
Corpus luteal blood flow. So then that shows that corpus luteum is a very healthy one, and you may expect a pregnancy. But if the RI is more than 0.5, then it is indicating LPD.
Very good point. Thank you, Rekha ji. Thank you so much. And thank you, Kanchan ji. Also, sorry, I have to log in for the another webinar at 10. So and I'm too hungry. First, I want to eat something, but the 2-3 minutes are left only.
So we should wind up, and we can't thank you enough for the we enjoyed the talk.
I also enjoyed, and Kanchan ji, thank you for such a nice presentation. Very nicely you have covered, and thank you, Rekha ji, for such a good take-home messages, and thank you, Yajini ma'am, and all dear friends who have joined.
Thank you.
Yeah.
Thank you. Bye. Good night.
Bye. Good night. Good night, ma'am. Take care. Yeah.
Thanks a lot. Okay.
Yeah. So, if
what is your talk at 10 p.m?
10 my Insta live is scheduled at 10 p.m. So 9 को था तो उसको मैंने 10 किया. अभी वहां से वो लोग मुझे पिंग कर रहे हैं बार-बार कि मैम when are you joining?
Best wishes.
Thank you.
All the
so
best,
much.
Ritu. Good night.
Yeah, thank you.
Thanks.